Yes.
Okay. Good evening, everybody. I'm so pleased to be here with you tonight, talking about anatomy of a paranasal sinuses and also application of anatomy to surgical theater and especially to functional sinus surgery. The key element to be a good surgeon is to be a good anatomist, because as the word can say, ana means through and tome means dissect, cut, resect. And so it appears clear that anatomy means that you have to go inside to the structure to understand the conformation. And therefore, it's quite important to perform cadaver lab work with cadaver dissection. That is the key point in order to improve your anatomical knowledge and also improve your surgical skills. So the key point is anatomy and step-by-step anatomical dissection. In order to learn something, the first things to learn is identify landmark. Second things, respect the anatomical structure you are encountering, avoid complication, and be safe in your movements. Identify your landmarks means that you have to be always able to understand exactly where you are located in the paranasal sinuses in order not to destroy structure and also not to enter in the brain, in the optic nerve, in the orbit. And therefore, second issue is to respect surrounding neurovascular structure that stay all around the paranasal sinuses. As you know, paranasal sinuses is in the center of the skull, very close to orbit, brain, carotid artery, and so very risky anatomical region. And so it's important to identify landmarks and respect anatomical structure all around in order to avoid complication. This is, for example, is a case where the surgeon put the suction tube inside to the brain, damaging the brain of the patient. And this is another condition where the surgeon destroy the lamina papyracea and also strip the anterior ethmoidal artery with such a results that is related to the orbital hematoma. This is another condition where there is pneumocephalus related to the interruption of the bony skull base. So it's important to avoid such a complication by identifying exactly anatomical structure all around. And to do that, you have to be very safety, you have to be very gentle in your movements, you have to understand anatomy, and you can also use some device to help you. For example, Osirix or also Horos are radiological software that you can install and download in your laptop, in your computer at home and office in order to better understand the radiological exams of a patient, because also the analysis of radiology is mandatory in order to plan a proper surgery. And besides preoperative planning and preoperative analysis of radiological exams, you can also use in selected cases navigation system. Magnetic navigation system is a very good tool in order to check the position of your surgical instruments within the surgical field and understand during surgery where you are working in order not to be disoriented and not to lose your surgical landmarks. So let's start to analyze the step-by-step procedure of functional endoscopic sinus surgery. As you know, the target of such kind of surgery is to obtain the patency of a sinus ostia. And so we have to start from maxillary sinus to ethmoid, to the sphenoid, and finally to frontal sinus in order to be able to identify the ostium and enlarge it as much as you can, as much as you need. So the ostium that you have to understand, that you have to look for and to reach are maxillary sinus ostium, frontal sinus ostium, and posteriorly sphenoid ostium. The first sinus that usually we approach is maxillary sinus. Maxillary sinus is the most commonly approached paranasal sinus, and as you know, is bounded behind posteriorly by the pterygoid plates of the sphenoid. Just inferior there are the teeth, and medially there is the medial wall of the maxillary sinus where inferior turbinate attach that divide maxillary sinus from the nose. Superiorly, you can see the floor of the orbit with inferior orbital fissure. So it's very particular sinus between different structures. And in order to approach maxillary sinus, the first things to do is to resect the inferior part of the uncinate process. Usually, our landmark is the floor of the bulla ethmoidalis. Staying at the level of the bulla ethmoidali floor, we can enter the infundibulum, which is a dead space just behind the uncinate process, and we can resect the inferior part of the uncinate process in order to expose the natural ostium of the sinus. This is an anatomical demonstration in cadaver lab with CT scan. So we can analyze the CT scan of a patient, identify nasolacrimal duct, which is the first landmark, and then the natural ostium of a maxillary sinus. Pay attention that to check the position of a medial wall of a maxillary sinus in respect to the papyrosia, because if the medial wall of a maxillary sinus is in line with the orbit, the surgery is more safe and easy to perform. Conversely, if the medial wall of the maxillary sinus is lateralized in respect to the papyrosia, it will be much more difficult to approach, much more difficult to open, with increased risk of orbital damages. So, preoperatively on the CT scan, it's quite important to check such condition, the position of the medial wall of the maxillary sinus in respect to the papyrosia. After that, we have to check the position of the bulla and the horizontal portion of the uncinate process in order to plan our surgical procedure. And this is anatomical dissection. Anatomical dissection, we identify our landmark, middle turbinate, floor of the bulla, you see, infundibulum. At the level of the infundibulum, we can see the vertical portion of the uncinate process, and we have to cut this inferior part because this is the insertion, the anterior insertion of the uncinate process. And so we are ready to start with the uncinotomy. Uncinotomy means that we are going to cut and resect the inferior part of the uncinate process. You can see, this is the inferior part of the uncinate process. We stay at the level of the floor of the bulla, and we are able to expose the natural ostium of the maxillary sinus. We can resect just a little more the uncinate process until the anterior insertion of the uncinate process. And you can see two different ostium. Natural ostium of a maxillary sinus is oriented in a oblique plane, while accessory ostium is usually vertical. After that, we can calibrate the ostium. We can join natural ostium with the accessory ostium in order to create a very big ostium. Okay, and this is maxillary antrostomy. You can also see at this level the impression of a second branch of a trigeminal nerve that runs at the level of the floor of the orbit. After that, we can remove completely the uncinate process. Okay, and we can extend superiorly the uncinectomy. In this way, we completely clean the infundibulum area and we can reach superiorly the axilla of a middle turbinate. You can see this is the uncinate process that has been cut at the level of its anterior insertion. And this is uncinate process cut. You can see the bullet moedalis here, the uncinate process. The uncinate process can be completely removed in this way, and you can see bulla floor, maxillary sinus, uncinate process completely removed. This is another case, but that in this case we perform live surgery. This is an alive patient. First, we cut just a little the polypoid degeneration of the head of the middle turbinate in order to increase the space in the infundibulum. After that, uncinectomy, we remove uncinate process. In this way, we cut uncinate process. You can see. We cut uncinate process. And after cutting uncinate process, we clean the infundibulum. This is a maxillary sinus. With a Stamberger forceps, we can just a little open and enlarge maxillary sinus, but this is done. Maxillary sinus, left side, bulla floor, middle turbinate. Once you are going to approach the maxillary sinus, it's quite important not to damage the nasolacrimal duct and the lamina papyracea. I have already told you that if the medial wall of the maxillary sinus is quite lateral, much more lateral than the orbital position, the opening of the maxillary sinus will be more difficult and more dangerous with increased risk of damaging the orbit. Conversely, when lamina papyracea and orbit are at the same level of a medial wall, it's much more easy to perform with less risk. A condition where there is a lateralization of a medial wall of a maxillary sinus is called silent sinus syndrome, which is a syndrome where inside the maxillary sinus there is a negative pressure and therefore the medial wall of the maxillary sinus is displaced laterally. You have to pay attention in managing such a kind of situation because of high risk of damaging the orbital floor. And so, not only orbit and lamina papyracea, but also nasolacrimal duct, as you can see and as you can understand, different possibilities of insertion of the uncinate process on the nasolacrimal duct. You can have uncinate process attached to the maxillary bone, to the lacrimal bone, like in this case, in different position. And so you have to understand such a kind of variability on the CT scan, on the preoperative CT scan, in order to understand exactly where the uncinate process attach. This way you can avoid damaging of a nasolacrimal duct. Usually there is a different consistency between the bone of a uncinate process and the lacrimal bone. And so you can feel different thickness of bone. Uncinate process is very thin, lacrimal bone is much more thick. And so you can stop your movement with a backbiting forceps when you feel very hard. Okay, once the maxillary sinus has been opened, we can move to the second sinus to be approached. Second sinus to be approached is the ethmoidal labyrinth, ethmoidal complexes. You can see ethmoidal complexes is very narrow space and very bleeding space, and you have to disassemble the ethmoidal complexes in order to clean the ethmoid without damaging orbit and brain and lateral lamella. The first cell to be opened at the level of the anterior ethmoid is the so-called bulla ethmoidalis. We have already seen this cell because when opening the maxillary sinus, we use the floor of the bulla as a landmark for opening the maxillary sinus. In this step, we have to remove the bulla, usually not doing that, but staying at the level of the inferomedial angle. By removing the bulla at the inferomedial angle is the safest position because you decrease the risk of damaging orbit that is lateral. And so once again, we can see the step-by-step cadaver lab dissection. You can see we are analyzing the CT scan from anterior to posterior. We identify the bulla ethmoidalis at that level. We can see bulla ethmoidalis also here in sagittal view. And we have also to understand the relationship between bulla ethmoidalis and the second portion of the middle turbinate. Another important structure to be identified during such a kind of dissection is the position of anterior ethmoidal artery. You see, this is the so-called nipple sign because it's a sort of nipple, anterior ethmoidal artery that run passing between medial rectus muscles and oblique superior muscles and is directed at the level of the roof of ethmoid. It's quite important to understand the position of anterior ethmoidal artery in order not to damage it. And so we can identify this position on the CT scan. This is the CT scan of a cadaver specimen we are approaching. And so we are now ready to do ethmoidectomy. First, we open the bulla, and after that, we remove the bulla. This is the natural ostrum of the bulla that is posterior to the bulla. And at the level of the inferomedial angle of the bulla, we are ready to remove this cell completely. It's important to remove completely the bulla, also the medial wall. You can see we are removing the bulla and we are cutting completely the mucosa. And just behind the bulla, we can see the ground lamella. The ground lamella is also called second portion of a medial turbinate. This bony septation divides the anterior ethmoid from the posterior ethmoid. And so it's a very important anatomical landmark. We clean completely the anterior ethmoid, you can see, and also we were able to see frontal sinus just up, you can see. We cut just a little more this area in order to clean completely the last remnant of the cell, you can see. We are cleaning completely the cells attached at the level of the roof of ethmoid in order to expose completely the roof and see anterior ethmoidal artery. This is anterior ethmoidal artery. Anterior ethmoidal artery is running from posterior to anterior, from lateral to medial in the right nasal fossa. Just anterior to anterior ethmoidal artery, we can see the first ethmoidal fovea, and just anterior, the frontal sinus, posterior wall of the frontal sinus. So it's quite important to identify anterior ethmoidal artery, not only because it's mandatory to avoid damaging the artery in order to avoid bleeding, avoid orbital hematoma, but also because anterior ethmoidal artery running at the level of the roof of ethmoid is a very important anatomical landmark to guide us to the frontal sinus. And this is another case, but in live surgery. This is left side. Before it was right side on cadaver lab. Now is left side in vivo patient. We are completely removing the bulla ethmoidalis. You see now there is also some bleeds that makes just more difficult the work. And you can see we have completely removed bulla ethmoidalis. Just behind the bulla ethmoidalis, we can identify the basal lamella, the second portion of the middle turbinate, dividing anterior ethmoidal cells from posterior ethmoidal cells, and just below sphenoid sinus. So from anterior to posterior, you can see anterior ethmoidal cells with uncinate process, bulla ethmoidalis, second portion of the middle turbinate, just behind posterior ethmoid, and finally sphenoid sinus. So you can see this is the progression of structure: uncinate process, ethmoidal bulla, second portion of the middle turbinate, also called basal lamella, just behind posterior ethmoid, and finally anterior wall of the sphenoid sinus and sphenoid sinus. We have to transpass from anterior to posterior all this structure in order to reach the sphenoid. But pay attention, because the skull base is not flat, but is going down. You can see it's going down. So moving from anterior to posterior, you have to be able and you have to be ready to approach the posterior ethmoidal roof just below. And so if you go straight on, you enter the skull. You have to correct your surgical instruments just below, because the skull base, the anterior skull base, is not flat, but is going down. Finally, you can see once again the shape of anterior skull base and the insertion of all this structure: uncinate process, middle turbinate, posterior ethmoid, and sphenoid sinus. Okay, it's quite important to understand all these structures in order to avoid the CSF leak. This is the position of anterior and posterior ethmoidal artery at the level of the roof of ethmoid. This is an in vivo case when we are cauterizing and cutting the anterior and posterior ethmoidal arteries. You can see, you can imagine such arteries running at the level of the roof of the ethmoid like the two hands, okay? Two hands at the level of the roof. This is right side, this is left side. This is right ethmoidal roof, this is left ethmoidal roof. You can see different position, different direction. In the right side, the direction is from posterior to anterior, from lateral to medial of the anterior ethmoidal artery, and posterior ethmoidal artery is in this direction, or more or less horizontal. Conversely, in the left side, the position of anterior ethmoidal artery is from posterior to anterior, from lateral to medial. You can see different position. In some cases, in rare cases, you can also identify the middle ethmoidal artery, another adjunctive artery in between the anterior and posterior. Another important thing to remember is that sometimes you can also have the essence of the arteries, and it's much more probably that you have the essence of anterior and posterior ethmoidal artery if you have highly pneumatized frontal sinuses, because much more is pneumatized the supraorbital recess, much more is pneumatized the frontal sinus, much more probably to have such a kind of dehiscence of anterior and posterior ethmoidal artery. So you have to be ready and able to understand these things on pre-operative CT scan in order to anticipate such condition. Okay? Sometimes you can also identify the middle ethmoidal artery. You can see anterior, posterior ethmoidal arteries, and in between middle ethmoidal arteries. It's not so frequent, but it's present in a percentage ranging from 15 to 40% of cases. It's running at the level of the roof of the ethmoid. After that, we can enter the second portion of the middle turbinate, and we can reach the posterior ethmoid. Once again, we are going to observe a CT scan of our cadaver specimen before performing cadaver lab dissection. Posterior ethmoidal artery, you can see. Sphenoethmoidal recess. In this position, it's important also to understand the pneumatization of the sphenoidal rostrum and then sphenoid sinus posteriorly. It's very important to understand also these, you can see. Pneumatization of the sphenoidal rostrum will give us the position of a natural ostium of a sphenoid. Much more pneumatized will be the rostrum, much more lateral we will see the natural ostium of a sphenoid. Another important thing to remember in radiology in sphenoid sinus is the position of the, is the position of the Vidian nerve, you see, Vidian nerve and second branch of the trigeminal nerve, because at the level of the sphenoid, this is the lateral recess of the sphenoid, and at the level of the basis sphenoid on the floor, you can see the Vidian nerve running sometimes together with palatovaginal artery. Conversely, at the level of the roof of the lateral sphenoidal recess, you can see the position of the V2, second branch of the trigeminal nerve, okay, in this position. Some septation inside of the sphenoid sinus. Then we can also analyze the axial view of the CT scan. Another important things, you can see such a kind of septation goes directly at the level of a paraclival carotid artery on right side. Also here, the intersphenoidal septum goes directly at the level of an internal carotid artery. This anatomical variation should be exactly understood before surgery in order to be ready to manage this situation and also not to perform such too much dissection at this level in order not to damage internal carotid artery. You can see this is the ostium of the sphenoid sinus. In this case, the ostium is good, is very medial because the rostrum is not pneumatized. Conversely, if you have had a very pneumatized rostrum, you can have the natural ostium of the sphenoid placed much more laterally. Okay, we are ready to start with our anatomical dissection. We have already opened maxillary sinus. We have already cleaned the posterior ethmoid. This is the ethmoidal roof. This is the third portion of the middle turbinate. This is the first portion of the middle turbinate. And this is the second portion of the middle turbinate. When performing functional endoscopic sinus surgery, the first portion should be left in place because it's very important for the nasal breathing. But also the third portion of the middle turbinate should be preserved because the third portion of the middle turbinate gives stability to the middle turbinate, give attachment of the middle turbinate laterally at the level of the lateral nasal floor. So, in order to approach the posterior ethmoid, we can clean and remove only the second portion of the middle turbinate, this basal lamella. This basal lamella should be completely removed in order to approach the posterior ethmoid. The position where to open the second portion of the middle turbinate is the so-called carrefour, so the joining point between third, second, and first portion of the middle turbinate. In that level, you can enter the second portion, and after that, we have to look for the tail of the superior turbinate. You see, we are transpassing the second portion of the middle turbinate in order to reach the posterior ethmoid. Once the posterior ethmoid has been reached, we can clean completely this area. We can clean completely this area. We can also remove mucosa in this case because we are performing anatomical dissection. We can insert our specimen, our Speculum also here in the posterior ethmoid passing through the paraseptal approach. Of course, this is the posterior ethmoid to be open, okay? This is another case but in vivo surgery where we perform the same step. We are opening the second portion of a middle turbinate. We are cutting the middle turbinate in this way, and we have opened the posterior ethmoid on the left side. Once again, this is another case, right side, where we perform all the surgical steps all together. Uncinectomy, identification of a natural ostium of a maxillary sinus, Stamberger forceps in order to calibrate the ostium, complete removal of the uncinate process, removal of the bulla ethmoidalis starting from the inframedial angle of the bulla ethmoidalis, cleaning of the anterior ethmoid completely in order to expose the second portion of the middle turbinate. When the second portion of the middle turbinate has been exposed, we have to approach the frontal recess. This is the frontal recess. We are following the upper part of the uncinate process, the so-called cranial insertion of the uncinate process, you can see. And by cutting the cranial insertion of the uncinate process, we were able to fully expose the roof and also identify the anterior ethmoidal artery on right side running at the level of the floor. So we have open maxillary sinus, we have completely clean anterior and posterior ethmoid. Now it's time to move to the sphenoid sinus. Sphenoid sinus, you can see sphenoid sinus just behind the tail of a superior turbinate. Sometimes also the supreme turbinate is present. And this is the natural ostium of the sphenoid sinus. The position of the natural ostium of sphenoid sinus strictly depends on the level of a pneumatization of the rostrum sphenoidalis, because much more the rostrum will be pneumatized, much more the natural ostium of the sphenoid will be lateralized. So this is an important variation that should be identified exactly on the preoperative CT scan. You can see in this case the natural ostium is very medial, very close to the nasal septum because the rostrum is very small. Conversely, in this case, the rostrum is large and therefore, in presence of such a highly pneumatized rostrum, the natural ostium of the sphenoid sinus is displaced laterally. So in this case, is very easy to perform paraseptal approach to the sphenoid sinus because the sinus ostium is medial. Conversely, in this case, if you perform a paraseptal approach, you encounter the rostrum, and so you will not be able to approach the sphenoid sinus. When there is a pneumatization of the rostrum, it's mandatory to perform a transethmoid approach to the sphenoid sinus in order to clean and remove also the anterior wall of the sphenoid sinus. Another important landmark to identify the natural ostium of the sphenoid sinus is the tail of a superior or supreme turbinate. Usually we have to look for such kind of tail using the transethmoid approach. In the transethmoid approach, we can see the tail of a superior turbinate and then we were able to enter in the sphenoid sinus. But pay attention because when approaching the natural ostium of the sphenoid sinus, sometimes you can have bleeding. You can have bleeding if you go too much below, too much low. Remember that just below the natural ostium of the sphenoid sinus, it's running the septal branch of the sphenopalatine artery. Septal branch of the sphenopalatine artery is the small arterial branch that supply the nasoseptal flap, the Haddad flap, of course, and sometimes can be damaged if you stay too much low when entering the sphenoid sinus. So my suggestion is to understand exactly where is the superior turbinate tail and draw such kind of line in order to understand that below this line you can have septal branch of a sphenopalatine artery and bleeding. If you stay up to the line, to the virtual horizontal line passing through the superior turbinate, you can enter directly on the sphenoid sinus. We are now on the left side, and remember that there is a very rich vascularization at the level of the basis sphenoid, very rich network of vessels at that level. And so you have to pay attention not to damage these branches in order not to have bleeding in your procedure. Remember, all the branches that are present at this level are in turbinal branches of the sphenopalatine artery for the inferior turbinate, turbinal branches of the sphenopalatine artery for the medial turbinate, septal branches of the sphenopalatine artery which supply the nasal septum, and after that we can also have other branches not associated with the sphenopalatine artery but arising directly from the maxillary artery, which are palatovaginal artery and Vidian artery. Another important things to have clear in mind is that sometimes some cell of the posterior ethmoid can overcome superiorly or laterally the sphenoid sinus. This cell of the posterior ethmoid is called Onodi cell, and this is the CT scan where is quite visible this. This is right side, on the right side, very huge sphenoid sinus until the roof. On the left side, conversely, the sphenoid sinus is small and below, and such a kind of septation is directly in continuation with the posterior ethmoid. And so, in this case, we have Onodi cell on the left side. Why Onodi cell is so important? First, because you can have problem in distinguishing Onodi cell from the sphenoid sinus. Remember, Onodi cell usually have a flat floor. Conversely, sphenoid sinus, there is a concavity. So it's important to understand that there is Onodi cell because you have to go to open the true sphenoid sinus below and not leaving that closed. Second problem, second critical issue associated with the Onodi cell is that usually inside the Onodi cell you can identify the impression of the optic nerve. So it's important to understand the presence of the Onodi cell in order to clean Onodi cell, identify optic nerve inside the Onodi cell, and also move your dissection below in order to open the sphenoid sinus and join Onodi cell to the sphenoid sinus. This is another case. On the right side, you can see, on the right side, it's visible. Left side, only one sphenoid. Right side, sphenoid below, Onodi cell up. And so we have identified Onodi cell, and this is Onodi cell, you see. This is not sphenoid, this is Onodi cell. You can see this is optic nerve running inside the Onodi cell, and this is posterior ethmoidal artery. It is quite dehiscent. Optic nerve, posterior ethmoidal artery, they are contained into the Onodi cell. This is posterior ethmoid, this is not sphenoid, and so we have to go on our dissection in order to clean below the true sphenoid sinus. You can see we are now working in order to open sphenoid sinus, and after that we cut the bone septation between Onodi cell and sphenoid sinus in order to join the two. You can see also what I told you. The floor of the Onodi cell is flat. The floor of the sphenoid sinus is with a concavity. So it's mandatory to understand that. Another important thing to have in mind is the different level of pneumatization of a sphenoid sinus that you can encounter. Highly pneumatized sphenoid sinus are called cellar sphenoid. Cellar sphenoid are better because you can exactly identify all the intrasphenoidal landmark in your sphenoid. Decreasing the level of a pneumatization from cellar to precellar and finally to concha sphenoid, you will have a very small sphenoid sinus, and usually all the anatomical landmark of the sphenoid sinus will be inside to the bone and so not visible. Okay, it's time now to see the same anatomical step in cadaver lab. You see, this is the caudal part of the superior turbinate. We are right side after removing the ethmoid. Now we have identified the lower part of the superior turbinate, and we are cutting the lower part of the superior turbinate in order to reach the natural ostium of the sphenoid. You can see we are cutting the lower part of the sphenoid, and you see the natural ostium of the sphenoid is just below and just behind. We are cutting the superior turbinate in this way, and after cutting the superior turbinate, we can identify the natural ostium of the sphenoid. After that, we enlarge the opening. We completely remove the anterior wall of the sphenoid sinus in order to clean the sphenoid sinus and enter the sphenoid sinus. You can see we are removing with the Seitelli forceps, carries on rounders. We are removing completely the anterior wall of the sphenoid. You can see. And we can identify our landmark inside of the sphenoid. First of all, we can see the optic nerve. Optic nerve is here in this position, and lateral recess of the sphenoid, impression of the second branch of the trigeminal nerve. You see, lateral recess of the sphenoid with median nerve and impression of a second branch of a trigeminal nerve. You see, median nerve, second branch of a trigeminal nerve. This is carotid, paraclival carotid, and this is optic nerve. And this is posterior ethmoidal artery, just anterior. It's quite visible also on the CT scan, the position of the anterior here, frontal sinus, first fovea ethmoidalis, anterior and posterior ethmoidal artery. Now we move our dissection on the other side. You can see. And here we are cutting the mucosa, and this is sphenoid ostium. We are performing now the pedicle of the so-called Haddad flap. Only to understand that in this area there is the septal branch of the sphenopalatine artery. You see, divergent incision V-shape in order to elevate the pedicle of the Haddad flap. In this way, you are safe, and you know that you are not damaging the septal branch of the sphenopalatine artery. We are completely removing here the rostrum, and once the rostrum has been removed, we have entered the sphenoid. Okay, in this case, we have also removed the intersphenoid sinus in order to join the two, in order to join left and right sphenoid sinus. And this is our landmark that are much more visible. Carotid artery is quite visible. You can see optic nerve, medial optocarotid recess, lateral optocarotid recess, internal carotid artery, medial cranial fossa. Okay, and this is quite visible. Okay, so we can see also in live surgery. First, in live surgery, we can see a paraseptal approach to the sphenoid. Paraseptal approach to the sphenoid can be performed in case of localization medially, localization of the natural ostium of the sphenoid, you can see. We are working on the natural ostium of the sphenoid sinus using a paraseptal approach in order to address the sphenoid sinus. Okay, conversely, we can perform sphenoidotomy also through a transethmoidal approach. Transethmoid approach to the sphenoid sinus entails the removal of a posterior ethmoid, identification of a tail of a superior turbinate, and once the tail of a superior turbinate has been identified, we can see the natural ostium of the sphenoid. You see, we are now inside to the sphenoid. This is our intrasphenoidal landmark. And you can see what to be observed inside of the sphenoid. From lateral to medial, median nerve running at the level of the basis sphenoid on the floor of the sphenoid. The second branch of a trigeminal nerve, it is also called V2, running at the level of the roof of the lateral recess of the sphenoid. Carotid artery, internal carotid artery clival segment, internal carotid artery in the cavernous segment, lateral and medial optocarotid recess, pituitary glands and cella floor, and this is the clival recess. Okay, and this is are once again all the landmark present at the level of the sphenoid. The sphenoid is very difficult to approach paranasal sinus, and also is very delicate because all these critical anatomical structure contained into. So dissection in the sphenoid sinus should be very gentle in order not to fracture, not to destroy, not to damage carotid artery, optic nerve, and pituitary gland. Finally, the last paranasal sinus to be approached is the frontal sinus. I left it at the end because frontal sinus is one of the most difficult paranasal sinus to be approached. And in order to understand how to approach, you have to exactly disassemble the anatomical structure of the frontal recess. Basically, the ethmoidal bulla, uncinate process, and the agar nazi cell. Because the three anatomical structure are working together in building up the frontal recess. Agar nazi cell and uncinate process at that level, and just below bulla ethmoidalis. So you have exactly to understand on the CT scan the shape of the cranial portion of the uncinate process and where it inserts, and also how much is big how the agar nazi cell in respect to bulla ethmoidalis, in order to exactly understand the route, the corridor to approach the paranasal sinus of the frontal sinus. You see different possibility of insertion of the uncinate process at the level of the papyresia or the level of the lateral lamella of the cribriform plate. It's quite important because in approaching the frontal recess, there is high risk of CSF leak, or cerebrospinal fluid leak, with the damage of the lateral lamella of the cribriform plate. You can see this is the nasal septum, this is the cribriform plate with olfactory phyla, this is the fova ethmoidalis that is big, very, very thick, but the lateral lamella of the cribriform plate is very thin, and this is the most fragile area of the skull base. And so in approaching frontal sinus, you have to be very, very safe and very cautious at that level. Because also you can analyze the shape and the direction of the lateral lamella of the cribriform vein before approaching the frontal sinus, in order to anticipate the level of risk of your procedure. In presence of very small and vertical lateral lamella, low risk, because it's quite difficult to damage this area. In case of very big lateral lamella and also oblique lateral lamella, high risk, because you can see very thin bone with a high risk of penetrating in the skull base. So once again, take in mind to check on the preoperative CT scan of your patient the shape and the length of the lateral lamella of the cribriform plate, because if you have a lateral lamella of the cribriform plate, like in this case, very long, very oblique, and very thin, the approach to the frontal sinus will be much more demanding and risky. If you destroy the lateral lamella of the cribriform plate, you can have pneumocephalus and also cerebrospinal fluid leak. And so it's quite difficult, it's quite important to understand. And another thing is that inside to the frontal sinus, we can have different cells and different type of cells. Kuhn classification is very common and very largely used, but recently P.J. Wormald has introduced another classification of intrafrontal cell that basically means that type 1 cell is when there is a single frontal cell at the level of Agernazi. Type 2 when there is another cell just up. Type 3 and type 4 when the cell is inside completely the frontal sinus. So how to approach the frontal sinus performing the so-called draft approaches. Usually, in the large majority of cases, you can only open the natural ostium of a frontal sinus, which is called draft type 1. But in selected cases, you can enlarge your approach in performing more extended approach, draft type 2 and draft type 3. This is an example of draft type 1, and then after that I show you draft type 2 and 3. Bullet moedalis, cranial portion of the uncinate process, you can see. So you have to disassemble the cranial portion of the uncinate process. You have to cut the cranial portion of the uncinate process in this way. And once the cranial portion of the uncinate process has been cut, you can reach the frontal sinus. This is the vertical bar. We are cutting the vertical bar and cutting the vertical bar, that is the cranial portion of the uncinate process. You can see frontal sinus orbit, and first portion of the middle turbinate. In selected cases, we can enlarge such an approach and perform draft type 2. Draft type 2 means that we are enlarging your opening of a frontal sinus until the insertion of a middle turbinate. This is called draft type 2A. In selected cases, you can enlarge also at the level of a septum, nasal septum, and this is called draft type 2B. But pay attention, you cannot enlarge frontal sinus here straight on, horizontally, because here there is anterior skull base, very risky area. Remember that is a sort of L shape, the opening of a draft type 2B. And so you can perform the draft type 1, only patency of a lateral ostium, draft type 2A, enlargement of the frontal sinus ostium until the insertion of a middle turbinate, draft type 2B until the nasal septum. Okay, anterior ethmoidal artery is quite important to be analyzed and to be observed. Is visible also here, the septal branch of anterior ethmoidal artery. It is another important landmark to have in mind and have under view. Okay, you can see supraorbital recess, right frontal sinus, well pneumatized. Sometimes you can also remove the intersinus septum, and removing the intersinus septum, you can join the right and left side, right frontal sinus, left frontal sinus, removing the intersinus septum. This is also called draft type 2C. Now I show you some anatomical video from live surgery, only to show you that sometimes in live surgery is much more difficult because the patient is bleeding, and so it's not so easy to understand all the anatomical structure I have shown you before. So we are cutting the vertical portion of the uncinate process. Once the vertical process of unit has been cut, we can identify frontal sinus. Okay? We are opening the bulla now on the right side. We are cleaning all the anterior ethmoid. And once the anterior ethmoid has been cleaned, we can identify the frontal sinus. You can see. We are cleaning now the frontal recess. We have removed and opened the agar nasicell. And once agar nasicell has been opened anteriorly, we can expose the frontal sinus in this way. You see frontal sinus on right side that is fully exposed. Once again, I show you draft type 2A. In draft type 2A, we have to enlarge the opening until the insertion of a middle turbinate. So we have to drill out, or we have to cut the floor of the frontal sinus until the insertion of a middle turbinate, like in this case. Okay. We are opening here all these structures. Once all the structures are open, you can see some pus, some secretion inside the frontal sinus. Once again, secretion. You can do some rinses and some irrigation inside to the frontal sinus in order to clean the sinus from the secretion. And we can completely open here, okay? Completely open frontal sinus, and it's visible the posterior wall of the frontal sinus. Finally, draft type 2B. Draft type 2B, we have to cut completely the middle turbinate, and the floor of the frontal sinus will be opened until the nasal septum. Sometimes we can check our work also using intraoperative navigation system. You can see we are removing the pus and the mucoid secretion inside to the frontal sinus. We perform some irrigation, and this is the final view. Frontal sinus open until the insertion of a nasal septum. Finally, sometimes you can also perform draft type 3. Draft type 3 means that we have to completely drill out the floor of a frontal sinus from orbit to orbit, including in the resection also the upper part of a nasal septum in its anterior aspect, in order to remove also the intersinus septum and join right and left frontal sinus. The anatomical landmark that can be used to perform draft type 3 are posterior wall of the frontal sinus and lacrimal sac. So these are all the landmarks that usually we use to perform draft type 3. Posterior wall of the frontal sinus, lacrimal sac in this position, common basal lamella of insertion of a middle turbinate, and then septal branches of anterior ethmoidal artery and first olfactory phyla. When you have some problem in approaching the frontal sinus, try to keep in mind all these landmarks in order to perform in a safe way draft type 3 approach. This is an anatomical dissection. We are drilling in this level. We are drilling in order to approach frontal sinus. You see, it is also called frontal median drainage. After that, we join the frontal medial drainage with the two drainages, laterally right and left, and this is orbit, and frontal sinus. This is another case in live surgery where we have performed draft type 3. We have to cut the insertion of a middle turbinate. Cut the insertion of a middle turbinate, you can see. Drill out completely the frontal beak of bone. remove the pus and the secretion inside to the sinus, you see. After that, drill once more the anterior wall, and you can see we have to drill out the upper part of the nasal septum. We have to remove the upper part of the nasal septum in order to join right and left side. We are removing the upper part of the nasal septum, we are removing all the septation inside to the frontal sinus, and finally, this is the results. You can see left side frontal sinus, right side frontal sinus, the area of insertion of the intersinus septum, but intersinus septum has been completely drilled out. The floor of the frontal sinus has been completely drilled out from orbit to orbit, and the upper part of the nasal septum has been removed. And so this is the much more extended approaches to the frontal sinus you can perform using an endoscopic endonasal approach. Well, I think that my time is almost finished, and so I would like to conclude. The conclusion of our lecture is very easy. The first conclusion is that anatomy is the key, and so my suggestion is to perform a lot of cadaver lab experience, because only in cadaver lab, by dissecting cadaver specimen, you can gain much more confidence with instruments, much more confidence with anatomical structure, and so cadaver lab is mandatory in order to understand, to do work, surgery, in live surgery. Another important thing to understand is that you have to follow a step-by-step learning curve. You cannot start from very difficult cases. You cannot start from cancer of the skull base, but you have to start from very easy cases. You can start from maxillary sinus, fungus ball, polyps, and so the learning curve should be respected, starting from easy things and then moving day by day, step by step, to things much more difficult, and only at the end manage very complex cases such as revision frontal sinus, revision sphenoid sinus, benign and malignant tumor of skull base, repair of CSF leak. And such a kind of learning curve, such a kind of step-by-step approach is mandatory and is very good, because you have to be able to manage possible complication. In order not to be afraid when we are doing surgery, you have to perform only the surgical step you are safe, only the surgical step you are able to do, and also be ready to manage possible complication. Otherwise, it's not safe to perform such a kind of surgery. I've finished, and I give you the greetings from our institution in Varese, in north of Italy. And also we invite you in our dissection courses that we organize. We have also restart in performing dissection courses. We have stopped dissection courses for COVID-19 infection, but now we have start once again in performing our courses, and so you are all invited to our courses. Thank you very much.
Mario, I'm sorry. I want to say thank you for such a great presentation, and our watchers wanting to ask you.
What? Sorry?
Do you have the possibility to answer 2 questions to?
Of course.
To our viewers?
Yeah.
Just a second, wait a minute.
Okay, if we completely remove Uncinetto's process, does it cause the general physiology of the nasal cavity?
No, the removal of the Uncinetto process does not affect the physiology of the nasal cavity. Don't you worry. It's much more important to respect the middle turbinate, because middle turbinate is crucial in nasal breathing and also crucial in moving the secretion from paranasal sinuses to the nose. but the complete removal of instrument process does not affect the nasal physiology.
Why do we need to completely remove basal plate of the middle turbinate?
We remove basal plate of a middle turbinate when we want to approach the posterior ethmoid. But you are asking when you completely remove all the middle turbinate? Your question is when you remove completely the middle turbinate?
Yes.
Okay. We completely remove the middle turbinate only in selected cases, usually in advanced skull base surgery, for example, tumor of the skull base, when we have to remove a lot of tissue in order to increase the working space, or when the middle turbinate is completely involved by the cancer or by the tumor. In inflammatory diseases, such as chronic rhinosinusitis with nasal polyps, usually we maintain the middle turbinate and only we reduce the shape of a middle turbinate, but we left in place middle turbinate. So we try to be much more conservative as you can in regard to the middle turbinate in inflammatory cases.
And another question, draft 3A, do we need to use navigator?
So,
guide?
If you have navigation, you can use it because it's much more easy and comfortable to perform draft type 3 and draft type 2B with navigation. It's not mandatory. I think that is mandatory to perform draft type 3, anatomical knowledge, because it's much more important anatomical knowledge than navigation. But if you have available navigation, you can use it. Usually we use navigation for draft type 3 to be much more confident.
And the last question, do we need to perform antrostomy in the middle turbinate with canine fossa punction in order to have better access to sinus, do we need to perform antrostomy in the middle nasal cavity plus punction of fossa canina?
So, to be honest, in the large majority of cases, standard medial meatal antrostomy is enough to work in the maxillary sinus, especially for inflammatory condition, inflammatory polyps. However, in very selected cases, you can add also canine fossa puncture in order to dominate and work at the level of the inferior part of the maxillary sinus. So we use canine fossa puncture, very rare, but sometimes can be useful.
So we don't have any more questions as for now, so we can call it
Mario, I think this is everything, all the questions for now. I think that we'll have more questions maybe after this 1 hour of your great presentation. I want to say thank you to you. And also, Vitaly joined us. And
Ciao, Vitaly!